And the K scale is called the correction scale. It's called the correction scale because it provides a factor to correct the clinical scales with. So there are several clinical scales, so I don't think it matters exactly which ones, where because it measures defensiveness, you can sort of factor that in to the scales. So you'll be adding a percentage of the raw K-score in order to sort of adjust for defensiveness. There are, when you look at scoring the MMPI, you can probably get K-corrected and non-K-corrected scales. And it's sort of a little tricky about when to use one or the other, and different books and different people say different things. For instance, Graham says that because most of the research is done on people with on K-corrected clinical scales, that we should always use the K-corrected clinical scales. Some people have argued that in people with higher education, you should use non-K-corrected scales. I say I trust the book of one of the people that have been most active researching the MMPI, and I tend to always use the K-corrected scales.
And I think that that's standard use for how to interpret the MMPI at our school too.
But there are times where you would say, I don't think the K-correction is measuring defensiveness. It might be measuring something else, and then you want to look at the difference between the K-corrected and the non-K-corrected scales. Again, it's important to know that the clinical scales will be corrected based on the defensive level. More in depth, you probably don't need to know for the constant list. So for the validity scales, are there any questions about the validity scales before we move on to the next set of scales? Okay, take that as a no. While the cutoffs, the T-scale cutoffs for the different validity scales sort of jump around a lot, and it's a lot of numbers to keep in mind, the nice thing about the clinical scales is that essentially you can always remember these sets of numbers and use those for all the clinical scales. Again, these numbers are based on green. Might be a little bit different depending on the source. But so low scores are anything lower than 44. That's actually a little bit more than half a standard deviation below the mean. That's 0.6 of a standard deviation below the mean. Normal would be 45 to 57. You could say a moderate elevation is going to be 58 to 64. Wow. So that's sort of you can start interpreting. You can see where things are. A marked elevation is sort of when you would really focus on that for interpretation. That's what sort of a high score would be, 65 to 89. And in some cases, essentially only for scale 7 and 8, you're going to have an extreme elevation, which would be a T-score greater than 90. Usually, you just look at marked elevation, but only for scale 7 and 8. Extreme elevations might have a slightly different interpretation. And we'll go over each one of those and see what they are. When I talk about the clinical scales, I'm going to talk about both the clinical scales and the Harris-Lengo scales together. Because I think looking at the Harris-Lengo scales, which you don't actually have to know all of them, but they help understand what the scale is measuring. Remember, the Harris-Lengo scales, which will be sort of below the description of the scale, can be seen as a factor analysis, or seeing what factors or what components make up the scale itself. So you would look at a scale that's elevated, and then you would go look at the Harris-Lengo scales to explain that elevation. Most books suggest that you do not look at Harris-Lengo scales when the clinical scale is not elevated. The reason for that is because some of the Harris-Lengo subscales rely on a very few number of items. So maybe there'll be 6 or 7 items that will cause a really high Harris-Lengo subscale to be high. but that's not really indicative of that personality pattern. So it's more they're more likely to be realistic or real or interpretable if the parent scale, the clinical scale, is high. Does that make sense? So in general, you don't look at the Harry's Lingos unless the parent scale is high. By high, I mean T of 65 or above. Are there times when you would want to look at the Harry's Lingo scales, even if there's not a marked elevation? Sure. But you have to be very, very careful that you're not over-interpreting it, because you might be interpreting something about, you might be making, saying something about somebody's personality based on 4 items. Not really valid. So scale 1, and you have to know the names of the scales, what they stand for. So for the comps and sort of just in general, if you're going to do assessment, if I say scale 1, you should be able to know which one is scale 1. If I say HS, you should also be able to know that that's scale 1, what that is. And you should also, which I didn't put, what HS stands for. And for scale 1 is hypochondriasis. Again, remember that these are often clinical terms that were used in the 30s, and they're not necessarily DSM terms now, but some of them still are. So we still have hypochondriasis. So people that score high on scale 2 are excessively concerned about vague physical symptoms, may use them to manipulate and control other people. They're cynical, whiny, demanding of attention, and generally negative and pessimistic. Generally. The prognosis for either psychological or physical interventions is guarded. So not really all that good. They're people usually with not all that much insight that are somaticizing a lot of their distress. There are no Harry's Lingo subscales for this, because that's all it measures. It's not like it can measure this or this. It's no. It just measures physical complaints. Done and done.
You have a question?
Oh, yes?
Are there any cultural factors with these scales? Like, for example, scale 1?
Zoe? I mean, they were all normed with a very Midwestern population. Actually, no, the MMPI-2 has a national sample, but they're still, they still pretty much represent things that are more consistent with sort of
Hold on, I'm looking at
more, sort of a more dominant culture. But we'll look into that and get back to you. Go.
I can get back to you right now.
Okay.
Sorry, I can get back to you in 2 seconds. Where was it?
Oh.
I was just. I'll come back to me. I was just looking at it this morning.
We'll get back to that in just a
Oh, no, I have it. Okay. So with scale 1, older people tend to score higher on scale 1. They also tend to score higher on scale 3, as a side note. And scales 1, 2, and 3 generally all increase with age. And that's the only notes that I have for scale 1 specifically. However, when we look at somatic symptoms, you look at just what you know from your own clinical experience, and there are some cultural or ethnic groups in which somaticizing symptoms tend to be a lot more common as manifestations of depression or anxiety, and that's predominantly in the Latino community. So I think that was what Manny was pulling for in his question, and I hope that answered it. So keep that in mind.
So scale 2 is the D scale, stands for depression. These clients exhibit a general sadness and depressed mood, either about life or about themselves. The scores increase. Also, pessimism, depression, and hopelessness begin to pervade and become sort of the dominant features of a person's entire life. Clients tend to be depressed, withdrawn, guilty, and self-deprecating. There are 5 Harry's Lingo subscales. D1 is subjective depression, which is sort of like they endorse feeling depressed. D2 is psychomotor retardation, which is a component that, really psychomotor retardation based on like the depression diagnosis needs to be observable by others. But here it's just like, are they sluggish? Are they feeling like they're not moving? So it's actually subjective, which is a little bit of a problem with this. D3 is physical malfunctioning. So as Zoe is saying, in a lot of different communities, depression symptoms actually come as somatic symptoms, and that takes that into consideration. D4 is mental dullness. DSM-wise, it would be sort of the difficulties concentrating, difficulty making decisions, and then D5 is brooding, which would be sort of the more ruminative aspects of depression. So this is sort of like the general description of what what elevations on scale 2 would be, and these are sort of like the factors that load onto that. Scale 3, HY, hysteria. Again, very old school term. These clients are naive, suggestible, like insight into their own and others' behaviors, and deny any psychological problems. Under stress, they can have physical symptoms, sort of a lot of similar to scale 1, but that's under stress, not always, and they're not vague, they tend to be more specific. Despite the initial positive impression they make on others, or in the clinician, sort of, they're difficult to treat. They're difficult. They tend to be not respond to interventions all that well. They usually look for very simplistic, concrete solutions to their problems, and look at solutions that don't require self-examination. The three different the Higgs-Lingo scales are denial of social anxiety, need for affection, lassitude, malaise, somatic symptoms, and inhibition of aggression. So they're sort of like the picture of the hysteric that Freud would talk about. Do you want to talk about the conversion triad before we move on, or do we do that later?
Oh, let's just do all the code types.
Okay.
We'll just handle them out.
Okay. So one way that that the scales. Let's one more. Scale 4. My favorite scale is why don't I? Oh, there we go. Scale 4, PD. Psychopathic deviate. So this is probing for antisocial behavior. These clients are fighting against something, only they know what, which is usually some sort of conflict with members of their family or authority figures. So like essentially the core part of this is conflict with authority. These conflicts may not necessarily be acted out overtly. The rebelliousness and anger towards others are readily apparent even in these cases. They're likely to be unreliable, egocentric, and irresponsible. They may be unable to learn from experiences or to plan ahead. So they're very they can be sort of impulsive and act before planning or thinking, and then are not really afraid of the consequences. They tend to be on first meeting them, they have a great social facade. They may be super nice, and then they might go and stab someone. They make a really good first impression, but eventually the psychopathic features will surface. In especially longer interactions or under stress, oftentimes they look to use people a lot. They're very nice to people, but only because they want to sort of manipulate them. Remember, these slides are going to be online. One of the reasons that I like Scale 4 is because psychology grad students are known to score really high on Scale 4.
So are adolescents.
Which makes sense sort of in adolescence. But anyway, so PD1, family discord, these are Higgs-Lingos, conflict with authority, social imperturbability, so they're not really affected by feedback from their environments, social alienation, and self-alienation, so alienation from themselves and other people. Scale 4 also has, and it's not really reflected here, also has sort of a more positive look, and that's sort of why psychology grad students tend to score really high. Because if you're sort of are able to take a step back from people and sort of look at them and appear really nice, but at the same time like be thinking about motives and other things. That means that people on scale 4 can actually fake empathy really well, or can show empathy really well, and are very, very attuned to other people's reactions, right? People that are psychopathic in tendencies do it to manipulate. We do it because we actually have genuine concern, hopefully, and want to help our clients. But there's a part of...
It's a fine line. It's a fine line.
It is. But in general, it is. It can also be sort of like this empathy and sort of attunement into other people.
So if you want to interpret it positively, you still look at a high score, or are you interpreting it with empathy and attunement with a low score?
So the question was whether or not you would need a high scale to like have a lot of those more positive implications, or I would say that that's probably more likely with moderate elevations. Like if it's very, very high, these other things are going to come out. But it's not uncommon for somebody, especially a grad student or a therapist, to score really high. And then you can still do it. It's important to note, and that brings up a really good point, that you wouldn't want to look at these scales in isolation. You really do have to bring it back to other things you know about them, their presentation. Like you wouldn't talk about the positive aspects if you give this to sort of an necessarily like 18-year-old criminal, or like somebody that has problems with the law, has been arrested. You're considering they might have a previous diagnosis of conduct disorder. You're thinking antisocial. If you see somebody that's like really nice, is involved in college counseling or something, or somebody that's in graduate school, you probably want to like say like this is what it measures, but it can also be these other things.
And I think that brings up a really important point too, like Marissa is saying, that you never do an interpretation without a context to place results in. And so it's really important because you'll be asked questions about assessment. Clinical interview is so important. And when you get asked multiple choice questions sometimes of like, what battery would you construct to address, like this isn't related to the MMPI, so sorry Mauricio, but what battery would you use to construct to assess, I don't know, like ADHD, or it'll give you like some arbitrary thing. Some of them won't include a clinical interview. And you know just to cross those out as options right away, because the clinical interview is the most important, fundamental tool of assessment that we have. So that plays into how you interpret these scales as well.
In fact, some really, hotshot assessment gurus don't like looking at tests as tests. They just consider them extensions to behavioral observations. So they're saying like, any test is just a way to elicit a certain behavioral response. I find that useful to think about. Something else, other things that could bring about scale elevations in scale 4 is people that, because of say childhood abuse, are very attuned to others because they tend to be very keen on looking at how other people respond to them. And something also that is sort of really important is PD1. That's another reason adolescents tend to score really high, and a lot of people, especially, it's family discord. If you have problems with your family, it's not necessarily that you're a psychopath. It might be that it might be related to your family environment. So you would, the first thing whenever I see a scale elevation of scale 4 is I immediately go to the Harris-Langell scales. Is it only high for family discord? Because then that's the interpretation I give. If these others are really low, chances are that it's not like this, descriptor is not going to be accurate. It's really just problems with family. And that's probably the one that I use the Harris-Langell as like the most in terms of interpretation, rather than just as backup. Oftentimes, like people that are sort of minorities within their family, so like transgendered or gay people, will tend to score really high on scale 4, only because they've been cut off by their families, or they've been alienated, or they've been like sort of persecuted. And it's not that they're psychopaths. Or they could be, but not all. And so one way that the scales are divided in sort of like lore is scales 1, 2, 3, and 4. No, scales 1, 2, and 3 are considered neurotic. And then, is 4 part of the neurotic scales? Do you remember?
No. The neurotic triad? No.
No, not the neurotic triad, but like, well, some people divide the scales like 1, 2, and 3 as like the neurotic scales, and then 6, 7, 8, 9 as the psychotic scales, because of the type of things they're probed. And I'm not sure scale 4 where that
I think it
fits
just hangs out by itself.
as the scale 5, which is really easy to ignore because it's not that validated and it's sort of pointless. All it measures is non-traditional gender interest. When it was developed in, I think, the 1970s, it was supposed to be a measure for homosexuality, back when that was a disorder that you wanted to look at. Essentially, it's scored differently for males and females. So, but it's been shown that it doesn't actually predict gayness or anything else. It sort of just says, well, how gender normative are your interests? So a lot of the questions that people laugh at when you give them the MMPI is like, I look to read car magazines. They're like, what does this do about my personality? Well, if you're a woman and you like to read car magazines, you're probably going to score higher on scale 5. If you're a man and you say that you like art shows, you're probably going to score high on scale 5 because the people that made the MMPI said those are traditionally masculine or traditionally feminine interests. There's no Harris-Lingo scale. There's a subscale developed by Martin in 1993. That's what they are. I'm not going to waste my time on a scale that I don't like.
Yeah, I don't like it either. But it should be noted that Latino males typically score higher on scale 5 when compared with other ethnic groups, and that elevation is usually 5 points higher. Machismo.
Scale 6. PA, paranoia. These clients are likely to be suspicious, hostile, and overly sensitive, and usually overtly verbalize these qualities. If it's high enough, you might want to consider a delusional or thought disorder. It measures ideas of external influence, so ideas of reference, people talking to them, poignancy, and naivete. So like, yeah, naivete would be sort of like reality testing, and poignancy would be like sort of the intensity of these things. Accurate? Again, you don't really have to know these. I'm putting them sort of together with this just because it often helps sort of to elucidate what this means. Scale 7, another one that we psychologists students tend to score very high on. So we would have a 4774 2-point code.
Is 6 PA, is it psychasthenia?
That's paranoia.
Paranoia.
PT is psychasthenia, which was sort of the old school anxiety scale. But not, it's a little bit different than anxiety. It doesn't have any Harris-Lingo scales, which indicates that it's sort of pretty homogeneous. So if you did a factor analysis on these items, they would all measure the same construct. Clients tend to be worried, tense, and indecisive. They may be very agitated at times. And it's a type of anxiety that is not just rumination, but rather it's an anxiety that is more physical and visible to others. If it's excessive, so if it's high, clients can be very agitated, have ruminations and obsessions, and the higher it is, the more likely they are to not be able to control their anxiety. Scale 8, SC, schizophrenia. Clients tend to feel alienated and remote from their environment, which may or may not reflect an actual psychotic process, or like distress. Difficulties in logic and concentration and poor judgment become apparent as more high this is. Usually intervention should be directive and supportive because it's people that have like more of a thought disorder. Extreme elevations would suggest acute severe situational stress. So people that, even if they're not sort of psychotic in any way, if they're going through a very difficult life transition, for instance, or they're having an identity crisis, they might score high on scale 8.
And it should be noted that African American individuals tend to have higher scale 8 scores when compared to other ethnic groups.
Something that often confuses a lot of students is thinking, high scale 8, that means they probably have some sort of psychotic disorder because they're schizophrenic. Actually, like the more delusional type thinking, the more that would actually come out more in scale 6. Scale 8 is more about alienation and about like difficulty, sort of cognitive like difficulties in terms of their environment. And that's actually really important, especially when you start thinking about how you're going to remember all those 2-point codes. Usually, like the contribution of scale 8 to any 2-point code is going to be the social alienation. Alienation from, they're going to be alienated socially, but also emotionally. They're not going to have the wherewithal, sort of cognitively. They have like lack of ego mastery, both cognitive, and they have sort of defective inhibitions. They're going to have problems in like inhibiting their responses. And then the last one, which I hate that little thing, is psychomotor dissociation. So like difficulty with certain tasks or actions. A high scale 8 in and of itself probably would not indicate a diagnosis of schizophrenia anymore. But if they have a high scale 6 and a high scale 8, that's probably going to be more conclusive to a sort of a real thought disorder. Any questions?
What does cognitive mean?
What does cognitive mean? Can you look at that? Cognitive. I've looked it up like 5 or 6 times and I never seem to. It's not there. Like the word is it's a weird sort of a weird word. But I can say it. So people that score high on that, which is SC4. They tend to feel that life is a strain. They experience depression and despair. They have difficulty coping with everyday problems and might worry excessively. Respond to stress by withdrawing into fantasy. Do not find their daily activities interesting or rewarding. They have given up hope of things getting better, or they may wish they were dead. That doesn't really say what cognitive is, but that's sort of what it's going at. So like there's lack of ego mastery cognitive, which is sort of the more logical processes. They might be losing their minds. They feel things like they're unreal. Cognitive is more like the emotional aspect of their cognitive experience. That's what it is.
Do you think that's relevant? Like, should we know that for the comps? Do you think that would be?
Yeah.
Okay.
That would be a fair question. Usually for a lot of the Harris lingos, you don't need to know the details about it. But somehow, Dr. Michael seems to think that that one is important. Because it does add to, like, it's not just a cognitive issue, but it's this affective issue of, like, distance from your own emotions and not having a control over your emotions. So, almost done with these. High scale 9, MA, stands for mania. Clients might be overactive, emotionally labile, and may experience a flight of ideas. Although they tend to have a positive euphoric mood, adverse of temper may occur. So a lot of, that's part of the lability, sort of like ups and downs. Clients are impulsive and might have an inability to delay gratification. We're seeing how a lot of these things also came up in like scale 8, right? Like impulsivity, problems with inhibition. That's actually one of the limitations of the clinical scales, that there's a lot of intercorrelation. So it's not on high to have elevation scale 8 and 9, due to this trait, and it's hard to tease out and that's when you would look at the Hypochondriasis. Sort of as more elevated, manic features might be more pronounced, flight of ideas, pressured speech, and they can be narcissistic or grandiose. The components of it are sort of like amorality, psychomotor acceleration, imperturbability, which means that they don't seem to learn very well. Like they can have negative things coming and they'll just like keep on going, sort of drive. And then ego inflation, this grandiosity. And the last one is scale 0. Some people say it's scale 10. Usually scale 0. SI, and that's social introversion. Social isolation? Introversion, yeah. And these clients might be introverted, shy, socially insecure. They withdraw from and avoid significant others. Again, might be correlated with scale 8. Serves to exacerbate any of the problems they have since others might not be able to help them because they don't ask for help. The likelihood of acting out is decreased. They tend to be ruminative. So, important to note, scale 8-0 is not technically considered like clinical. Like 5 and 0 are sort of more personality. They're not usually they're not as diagnostic as the others. Components are sort of like shyness, self-consciousness, social avoidance, and then alienation from self and others. Again, similar to some of the other ones. I usually like to compare scale 0 to the scale S, the validity, the superlative scale, because they tend to go together. People that are very shy are probably going to score very low on scale S. Whereas the other way around, if they score really low here, because they're not introverted, they probably will have a more superlative presentation. They're going to be more social and more out there. Are there any questions about the validity scales?
I have a question.
Uh-huh.
Should we take a quick break and then do the code types because they all pertain to these, and then go to the content?
Yeah, that's what I was thinking.
Okay. So let's take a
10-minute break.
10-minute break.
And then we'll be back. We'll do some. We'll look at different code types, which you have to know, and then we'll briefly look at the rest of the scales and the rest of the MMPI, as well as the MMPI-A and the MMPI-RF.